Welcome to our lecture on Advanced Restorative Dentistry, where we'll explore cutting-edge techniques for enhancing dental function and aesthetics. We'll cover micro-abrasion and bleaching techniques, localized composite resin restorations, veneers, adhesive metal castings, and composite resin onlays. Additionally, we'll discuss the management of tooth discoloration, tooth surface loss, inherited anomalies like molar incisor hypomineralization, MIH, and hypodontia. Let's dive into these topics to gain insights into the latest advancements in restorative dentistry. Hydrochloric acid pumice microabrasion technique. Introduction. Controlled method for removing surface enamel to improve discolorations limited to the outer enamel layer. Combines abrasion and erosion, sometimes referred to as abrosion. Enamel removal should not exceed approximately 100 mm. Excessive removal can damage the pulp and reveal underlying dentin color. Indications: fluorosis, idiopathic speckling, post-orthodontic treatment, demineralization. Prior to localized composite restorations or veneer placement for well-demarcated stains. White/brown surface staining, e.g., Turner teeth, armamentarium. Bicarbonate of soda/water. Soft white paraffin. Fluoridated toothpaste. Pumice. Rubber dam and rubber prophylaxis cup. Soflex discs, 3M. 18% hydrochloric acid. Technique. Conduct preoperative vitality tests, take radiographs and photographs. Clean teeth with pumice and water, then wash and dry. Isolate teeth with rubber dam, placing soft white paraffin under the dam. Apply mixture of sodium bicarbonate and water on dam behind teeth for friction. Mix 18% hydrochloric acid with pumice to form slurry. Apply small amount to labial surface for 5 seconds using rotating rubber cup or wooden stick, then wash for 5 seconds into aspirator tip. Repeat up to 10 5-second applications per tooth. Remove rubber dam. Polish teeth minus Soflex discs. Polish teeth with fluoridated toothpaste in rubber cup for 1 minute. Review in a month for outcome assessment, vitality tests, and clinical photographs. Biannual reviews for pulpal status checking. Critical analysis. Effectiveness assessment should be delayed for at least a month. Brown mottling is typically removed more easily than white. Abrosion technique alters optical properties of tooth surface, making white mottling less perceptible. Long-term studies show no association with pulpal damage, increased caries susceptibility, or significant prolonged thermal sensitivity. Patient compliance and satisfaction are generally high. Failure to improve appearance has no harmful effects and may facilitate masking lesions with veneers or composite restorations. Non-vital bleaching. Overview. Technique for bleaching discolored teeth due to the diffusion of hemoglobin breakdown products from necrotic pulp tissue into dentinal tubules. Indications. Discolored non-vital teeth with well-condensed gutta-percha root filling. No clinical or radiological signs of periapical disease. Contraindications. Heavily restored teeth. Staining due to amalgam, armamentarium. Rubber dam. Glass ionomer or IRM cement. 37% phosphoric acid. Bleaching agent, sodium perborate, hydrogen peroxide, or carbamide peroxide. Cotton wool. White gutta-percha. Composite resin. Non-setting calcium hydroxide. Technique. Take preoperative periapical radiographs. Clean teeth with pumice and note the shade of the discolored tooth. Isolate the single tooth with rubber dam. Remove palatal and pulp chamber restorations. Remove root filling to 1 mm below the dentogingival junction. Place 1 mm of cement over gutta-percha. Freshen dentine with a round burr. Etch pulp chamber with 37% phosphoric acid, wash, and dry. Apply bleaching agent into the pulp chamber, either alone or on cotton wool pledget. Place dry cotton wool over the mixture. Seal the cavity with glass ionomer cement. Repeat weekly until slightly overbleached. Place non-setting calcium hydroxide into the pulp chamber for 2 weeks, then seal with glass ionomer cement. Finally, restore the tooth with white gutta percha and composite resin. Considerations. If tooth color does not significantly improve after 3 bleach changes, further bleaching may be ineffective. Slight overbleaching is desirable, but significant overbleaching should prompt the patient to return before the next appointment. Non-vital bleaching may cause tooth brittleness, possibly due to previous dentine removal rather than the bleaching procedure itself. Associated with the later occurrence of external cervical resorption, possibly due to hydrogen peroxide diffusion through dentinal tubules. Advantages. Easy for both operator and patient. Conserves tooth tissue and maintains original crown morphology. No irritation to gingival tissues. No problems with changing gingival level compared to veneers or crowns. No technical assistance required. Clinical studies. Long-term studies show a 21% failure rate after 8 years, with expected regression. Recommendation. Caution advised when using hydrogen peroxide mixed with sodium perborate crystals due to potential complications. 1 mm layer of cement placed to cover openings in tubules and reduce the risk of inflammation in the periodontal ligament. Vital bleaching, chairside. Overview. External application of hydrogen peroxide to tooth surface followed by activation with a heat source. Lengthy and time-consuming procedure requiring high patient compliance. Indications. Very mild tetracycline staining without obvious banding. Mild fluorosis. Yellowing due to aging. Single teeth with sclerosed pulp chambers and canals. Armamentarium. Rubber dam with clamps and floss ligatures. Ore-based paste. Topical anesthetic. Gauze. 37% phosphoric acid. Heating light with rheostat. 30 to 35% hydrogen peroxide. Polishing stones. Technique. Take preoperative periapical radiographs and perform vitality tests. Replace any leaking restorations. Clean teeth with pumice and water, note the shade of discolored tooth, and take preoperative photographs. Apply topical anesthetic to gingival margins and coat buccal and gingivae with ore-based paste. Isolate each tooth with rubber dam and individual ligatures. Etch labial and a third of palatal surfaces with phosphoric acid for 60 seconds, then wash and dry. Soak gauze in hydrogen peroxide and cover teeth to be bleached. Position heat lamp and a temperature until patient feels warmth but no sensation. Keep gauze damp by reapplying hydrogen peroxide every 3 to 5 minutes. After 30 minutes, remove rubber dam, clean off ore-based paste and polish teeth with shofu stones. Apply fluoride drops. Monitor postoperative sensitivity and provide relief with paracetamol if necessary. Assess change, may require 3 to 10 treatments per arch. Treat 1 arch at a time. Rebleaching may be required after a year or more. Take postoperative photographs with original Vita shade tooth included. Considerations. Timing procedure requiring patient motivation. Can be used for discoloration caused by pulp chamber sclerosis. Retreatment may be necessary. Vital bleaching, night guard. Overview. Daily placement of carbamide peroxide gel into custom-fitted tray worn by patient at home. Indications. Mild fluorosis. Moderate fluorosis as an adjunct to hydrochloric acid, pumice micro-abrasion. Yellowing due to aging. Single teeth with sclerosed pulp chambers and canals. Selective bleaching for aesthetic purposes. Armamentarium. Upper impression and working model. Soft mouthguard. 10% carbamide peroxide gel. Technique. Take alginate impression and cast working model. Make acrylic vacuum-formed splint as mouthguard, relieving labial surfaces of teeth. Instruct patient on flossing and application of gel into mouthguard. Where time depends on product used, Review after 2 weeks and again at 6. Safety considerations. Carbamide peroxide gel breaks down to 3% hydrogen peroxide and 7% urea in the mouth. No long-term safety studies, but short-term use considered safe. Initial decrease in bond strengths of enamel to composite resins returns to normal within 7 days. Minor ulceration or irritation may occur initially, adjust exposure time if necessary. No long-term studies on safety, further research needed. Legal considerations. It is illegal in the UK to supply a product containing or releasing more than 0.1% hydrogen peroxide for tooth whitening. Seek medical legal advice when considering such products for clinical use. Inside-outside bleaching technique. Overview. Alternative approach for managing discolored endodontically treated teeth. Combination of walking and vital bleaching techniques. Procedure. Prepare tooth similar to walking bleach technique, focusing on removing gutta percha below the cementoid junction. Seal root canal from oral cavity with barrier, e.g., glass ionomer cement or IRM cement. Construct custom-made tray with small reservoir palatal to affected tooth only. Use 10% carbamide peroxide gel, placed by patient into access cavity of non-vital tooth tray. Wear tray full time for up to 4 days, replacing gel every 2 to 4 hours. Once aesthetically acceptable result achieved, refill access cavity appropriately. Considerations. Long-term results not yet available. Relapse possible, similar to other bleaching techniques. Advantages. Provides an alternative approach for managing discolored endodontically treated teeth. Combines aspects of walking and vital bleaching techniques. Localized composite resin restorations. Overview. Restorative technique utilizing recent advances in dental materials to replace defective enamel with a restoration that bonds to and blends with enamel. Indications. Well-demarcated white, yellow, or brown hypomineralized enamel, such as those seen in molar incisor hypomineralization, MIH. Armamentarium. Rubber dam/contoured matrix strips. Round and Fisher diamond burrs. Enamel, dentine bonding kit. New generation highly polishable hybrid composite resin. Soflex discs, 3M and interproximal polishing strips. Technique. Take preoperative photographs and select shade. Apply rubber dam and contoured matrix strips if needed. Remove full extent of demarcated lesion with a round diamond burr down to the amelodentinal junction, ADJ. Chamfer enamel margins with diamond Fisher burr if required. Cavity margins, wash and dry. Apply prime and bonding agent according to manufacturer's instructions. Apply chosen shade of composite, shape with lubricated brush and light cure. Remove matrix strip/rubber dam. Polish with graded Soflex discs, finishing burrs, interproximal strips as needed. Add characterization to composite surface. Take postoperative photographs. Advantages. Quick and easy procedure. Often no significant sensitivity, hence no need for local anesthesia. Advances in bonding and resin technology simplify restorations and eliminate need for full labial veneer. Disadvantages. Marginal staining. Accurate color match required. Suboptimal aesthetics if full extent of demarcated lesion is not removed to the ADJ. Composite veneers offer a conservative and satisfactory alternative to porcelain jacket crowns, PJCs, for children and adolescents. Can be direct, placed in a single appointment, or indirect, fabricated in the laboratory. Indications. Discoloration, enamel defects, diastematia, malpositioned teeth, large restorations. Relative contraindications. Insufficient tooth tissue available for bonding, oral habits, e.g., woodwind musicians, occlusal factors, armamentarium. Rubber dam/contoured matrix strips. Preparation and finishing burrs. New generation highly polishable hybrid composite resin. Soflex discs and interproximal polishing strips. Technique. Reduce labial enamel if appropriate. Clean tooth and select shade. Isolate tooth with rubber dam and contoured matrix strip. Etch enamel and apply priming and bonding resin. Apply composite resin to labial surface, shaping and curing as needed. Remove contour strip and finish margins and surface. Add characterization for improved light reflection properties. Types of composite veneers. Intra-enamel or window preparation. Incisal bevel. Overlapped incisal edge. Feathered incisal edge. Considerations. Tooth preparation may expose dentine in cases of localized hypoplasia or caries. Composite veneers can last through adolescence until porcelain veneers are considered around ages 18 to 20. Advantages. Conservative approach compared to PJCs. Can be completed in a single visit. Durable enough to last through adolescence. Disadvantages. Marginal staining and color match challenges may arise. Suboptimal aesthetics if full extent of lesion is not removed. Inappropriate in cases where orthodontic treatment is planned. Porcelain veneers. Advantages of porcelain over composite. Superior appearance. Better resistance to abrasion. Well tolerated by gingival tissues. Considerations for successful porcelain veneers. Precise fit is crucial. Keep luting cement film thickness to a minimum. Use of luting cement should be carefully considered due to potential water absorption, hydrolysis, and staining. Gingival margin stability, especially in young patients, is important for long-term aesthetic success. Non-standard application, restoration of PEG lateral incisor. Utilizes a no preparation technique. 3/4 wraparound veneer finished to a knife edge at the gingival margin. Elastomeric impression taken after gingival retraction to obtain maximum crown length. Cementation should be formed under rubber dam for optimal results. Advantages. Provides superior aesthetics compared to composite. Suitable for cases where direct composite resin restoration is unsuitable, such as restoration of PEG lateral incisors. Disadvantages. Requires precise and careful management of luting cement. Gingival margin stability is crucial for long-term aesthetic success, especially in younger patients. Adhesive metal castings for retained cast restorations. Advantages. Minimal or no tooth preparation required. Ideal for cases where there is a risk of tooth tissue loss. Durable and long-lasting. Indications. Amelogenesis imperfecta. Dentinogenesis imperfecta. Dental erosion, attrition, or abrasion. Enamel hypoplasia. Armamentarium. Gingival retraction cord. Elastomeric impression material. Facebow system. Semi-adjustable articulator. Rubber dam. Panavia X, curare, or similar adhesive cement. Technique. Obtain study models and photographs if possible. Perform a full mouth prophylaxis. Ensure good moisture isolation. Place a retraction cord into the gingival crevices of the teeth to be treated. Take an elastomeric impression, ensuring clear margin definition. Take a facebow transfer and interocclusal record. Mount the casts on a semi-adjustable articulator. Construct cast onlays a maximum of 1.5 mm thick occlusally in nickel chrome or gold. Grip blast the fitting surfaces of the occlusal onlays. Check the fit of the onlay and sandblast before fitting. Polish the teeth and isolate under rubber dam where possible. Cement onlays using Panavia X or similar adhesive cement. Check occlusion and record any discrepancies. Review periodically to assess occlusion and overall restoration function. Considerations. Treatment may be challenging for some children due to high levels of patient cooperation required. Local anesthesia may be needed due to sensitivity of hypoplastic teeth. Moisture control can be difficult. Rubber dam is preferable but not always feasible. Disruption of occlusovertical dimension should be anticipated but is usually well tolerated. Aesthetic concerns may arise if metal shines through translucent incisal tips without proper luting cement. Long-term durability. 10-year evaluation studies confirm the durability of this restoration technique. Indirect, composite resin onlays. Advantages. Aesthetic advantages over cast metal onlays. Ease of modification for ongoing conditions like erosion. Studies suggest durability in the anterior region. Increasingly used in the posterior region to meet patient demand. Disadvantages. Need to be thicker than cast counterparts. Bulkier. Can cause greater increases in vertical dimension. Durability in the posterior region is currently unclear. Considerations. Despite being thicker and bulkier, well tolerated in young patients if occlusion remains balanced and there is no periodontal pathology. Tooth discoloration. Importance. Color of a child's teeth can significantly impact self-esteem due to peer group pressure and teasing. Causes. Congenital/acquired. Enamel/dentine. Extrinsic/intrinsic. Systemic/local. Classification for clinical management. Identifying the main site of discoloration aids in choosing the most appropriate treatment method. Treatment approach. Emphasis on minimal tooth preparation to preserve long-term tooth health. Significant improvements achievable without compromising teeth. Ideal and permanent results may not be realistic in young patients. Specific cases. Fluorosis, micro-abrasion may produce improvement, followed by composite veneers or porcelain veneers in late teenage years. Non-vital dark incisor, composite veneer or jacket crown may be options. Tetracycline discoloration, long-term full crowns or porcelain veneers often required, with composite veneers as an interim solution in adolescence. Managing patient expectations. Unrealistic expectations should be addressed preoperatively with adequate explanation and documentation. Expectations of patients and parents must be considered and managed effectively. Preoperative explanation, preferably with photographic examples, can help minimize postoperative dissatisfaction. Careful documentation of all cosmetic treatment cases is essential for medico-legal reasons. Tooth surface loss, TSL, in children. Overview. TSL, also known as non-carious loss of tooth tissue, has become increasingly prevalent among the younger population. Main contributors: attrition, erosion, abrasion. Causes. Attrition, wear due to tooth contact, common in primary dentition. Erosion, irreversible loss of tooth substance by chemical processes, not involving bacteria. Abrasion, physical wear of tooth substance, often due to overzealous toothbrushing. Prevalence. Assessing prevalence is challenging due to normal age tooth tissue loss. Smith and Knight described a tooth wear index, TWI, to assess pathological tooth wear. Limited published evidence on prevalence in children. National Children's Dental Health Survey, 2003, reported 53% of 5-year-olds with evidence of TSL on palatal surfaces of primary incisors. Prevalence increases in adolescence, with 33% of 15-year-olds showing TSL on palatal surfaces of incisors. Clinical signs. Pulp exposure. Loss of vitality. Exposure of secondary dentin. Cupped occlusal/incisal surfaces. Restorations projecting above tooth surface. Sensitivity. Reduction in incisal tooth length disproportionate to width. Causes of TSL in children. Dietary factors, excessive intake of acidic foods/drinks, such as citrus fruits, carbonated drinks, alcoholic beverages. Gastric regurgitation, gastric reflux associated with various upper gastrointestinal disorders and eating disorders like anorexia nervosa and bulimia nervosa. Parafunctional activity, habits like overzealous toothbrushing. Pattern of TSL. Varies based on the cause and manner of substrate consumption. Carbonated drinks often lead to generalized enamel loss and saucer-shaped lesions on molars. Specific habits, like frequent consumption of acidic drinks via straw, can lead to localized erosion. Detection and management. Dentists play a crucial role in identifying signs of gastric regurgitation or eating disorders through the observation of erosive TSL. Early detection and collaboration with medical professionals are essential for appropriate management. Conclusion: tooth surface loss in children is multifactorial, with dietary, gastrointestinal, and behavioral factors contributing. Dentists must be vigilant in identifying signs of TSL and collaborating with medical colleagues for comprehensive management. Parafunctional activity and tooth surface loss, TSL. Overview. Localized TSL often correlates with abnormal parafunctional habits, such as excessive grinding, which may not be obvious to the patient. Signs of bruxism include muscle hypertrophy, cheek biting, tongue faceting, and tooth tissue loss. Examples. Patients with cerebral palsy often exhibit chronic gastric regurgitation and severe bruxism, leading to extensive TSL. Management. Immediate, early diagnosis is crucial. Treat dental sensitivity resulting from TSL while addressing the underlying cause. Elimination of cause. Establishing the cause and eliminating it is essential. Dietary counseling plays a significant role, focusing on personal, practical, and positive advice. Patients should be educated on alternatives to erosive foods/drinks and to limit intake, especially outside of meal times. Practical suggestions for patients. Dietary causes. Offer positive alternatives to erosive substances. Encourage limited intake of carbonated drinks, preferably during meals. Provide personalized dietary counseling tailored to each patient's habits and preferences. Management of dental sensitivity and erosive tooth surface loss, TSL. Dental sensitivity. Erosive TSL can lead to rapid pulp inflammation due to large pulp chambers. Secondary dentine formation may not occur in time. Promoting mineralization with calcium and phosphate uptake may reduce sensitivity and further tissue loss. Casein phosphopeptidomorphous calcium phosphate, CPPACP, technology, such as tooth mousse, delivers calcium and phosphate to the tooth surface, potentially reducing sensitivity. Temporary coverage with glass ionomer cements or resin-based composites may provide relief. Despite some controversy, glass ionomer cements can offer temporary relief, especially when resin-based materials are too painful initially. Practical prevention of erosion. Inform patients about erosive food and drinks. Encourage consumption of still/non-carbonated drinks as alternatives. Limit intake of acidic foods/drinks to meal times. Suggest consuming neutral foods, e.g., cheese, immediately after meals. Advocate the use of neutral fluoride mouthwash or gel for daily use. Recommend bicarbonate of soda mouth rinse for recurrent gastric reflux. For marked attrition, suggest using neutral fluoride gel in an occlusal guard at night or during vomiting episodes. Definitive treatment. Early diagnosis may allow preventive counseling to be sufficient. Making study casts for monitoring where progression can be helpful. Intervention is required for advanced cases with sensitivity or cosmetic concerns. Treatment objectives include resolving sensitivity, restoring missing tooth surface, preventing further tissue loss, and maintaining a balanced occlusion. Compensatory growth and management of malocclusion. Compensatory growth. In cases where compensatory growth or significant malocclusion limits space for restorations, interventions may be necessary to create sufficient space. For example, a patient with a Class II, Division II malocclusion and second palatal tooth tissue loss from erosive drink consumption and attrition may require a removable appliance with a flat anterior bite plane. The appliance reduces overbite, creating space via the Dahl principle, where compensatory overeruption of posterior segments occurs, typically within 6 weeks. Once adequate space is created, cast metal palatal veneers can be placed, or palatal veneers can be directly applied without an initial appliance. Restoration of posterior teeth. Marked wear of posterior teeth may necessitate restoration and protection from further wear before placing anterior restorations. Cast adhesive occlusal onlays are recommended to restore occlusal surfaces and provide resistance to abrasive wear. Young patients can easily accommodate the increase in vertical dimension if a balanced occlusal contact is achieved, facilitated by a face-bow record. Indirect composite veneers. Indirect composite veneers offer advantages in cases with unclear etiology or when patients cannot stop habits causing wear. These restorations allow future additions and repairs using direct composite if erosion continues. Median survival times exceeding 4 years have been reported for such restorations in the anterior dentition. However, in cases of attrition or parafunction, composite onlays may not be durable enough in the posterior segments, making cast restorations the preferred option. Long-term review for patients with tooth surface loss, TSL. Monitoring future TSL. Regular reviews are essential to monitor the progression of TSL and identify any new areas of concern. Changes in eating habits, oral hygiene practices, or underlying health conditions may affect the rate of TSL. Maintaining existing restorations. Existing restorations need regular examination and maintenance to ensure their longevity and effectiveness. Any signs of wear, deterioration, or damage to restorations should be addressed promptly to prevent further complications. Providing support for the patient. Patients with TSL, especially those with eating disorders, may experience periods of relapse. Dentists play a crucial role in diagnosing and supporting patients during these periods, offering both dental care and emotional support. Building a trusting and supportive relationship with the patient over the long term and providing encouragement and guidance. Reinforcing good dietary habits. Continuous reinforcement of good dietary habits is essential throughout the patient's life, especially for those with dietary erosion. Dentists should provide ongoing education and counseling on the importance of healthy dietary choices and their impact on health. Anticipating and addressing changes in dietary habits as patients age is crucial to prevent ongoing erosion and TSL. Conclusion: regular long-term reviews for patients with TSL are essential for monitoring progression, maintaining existing restorations, providing support, and reinforcing good dietary habits. Dentists play a crucial role in building trusting relationships with patients and offering ongoing care and guidance to promote oral health and prevent further deterioration. Treatment of amelogenesis imperfecta and dentinogenesis imperfecta. Challenges. Wide variety of presentations, each case varies in severity, making generalizations challenging. Early diagnosis, critical for long-term prognosis, allows for early monitoring and intervention. Specific clinical problems. Poor aesthetics. Enamel chipping and attrition. Dentine exposure and attrition leading to sensitivity. Poor oral hygiene, gingivitis, and caries. Principles of treatment planning. Individualized approach. Treatment plans must be tailored to patients' unique needs and circumstances. Minimal intervention. Emphasize preserving tooth tissue and minimizing invasive procedures. Primary dentition care, ages 0 to 5. Prevention. Provide dietary advice for optimal oral health. Consider fluoride supplements as appropriate. Instruct caregivers on effective oral hygiene practices for children. Restoration. Aim for aesthetic outcomes in restorative procedures. Utilize glass ionomer cement, GIC, and stainless steel crowns, SSCs, especially for lesions affecting the primary molars, ES. Aesthetic considerations. Emphasize minimal intervention approaches to preserve natural aesthetics. Mixed dentition care, ages 6 to 16. Prevention. Offer dietary guidance to support oral health. Implement fluoride therapy based on individual needs. Provide comprehensive oral hygiene instructions, possibly including the use of chlorhexidine mouthwash. Restoration. Consider stainless steel crowns, SSCs, for primary molar restorations. Apply adhesive castings for the first permanent molars. Utilize localized composite or glass ionomer cement, GIC, for restorative procedures. Aesthetic considerations. Direct composite veneers for aesthetic enhancements. Consider indirect composite or porcelain veneers for more extensive aesthetic improvements. Provide dentures as a solution for missing teeth, ensuring aesthetic harmony with the natural dentition. Permanent dentition care, ages 16 plus. Prevention. Offer thorough oral hygiene instruction tailored to individual needs. Administer fluoride therapy as part of preventive measures. Consider the use of glass ionomer cement, GIC, for specific restorative needs. Restoration. Apply adhesive castings on premolars to restore functionality and aesthetics. Consider full mouth rehabilitation for comprehensive restoration of dental function and aesthetics. Offer overdentures as an option for preserving remaining teeth and enhancing stability. Provide complete dentures for ill patients to restore masticatory function and aesthetics. Aesthetic considerations. Offer porcelain veneers for aesthetic enhancement of tooth appearance. Consider full crowns for comprehensive restoration of damaged or discolored teeth. Provide overdentures and complete dentures with aesthetic conditions to ensure natural-looking results. Prevention. Oral hygiene. Provide sympathetic instruction and continuous reinforcement. Restorative/cosmetic treatment. Address enamel hypoplasia to facilitate effective brushing. Caries prevention. Implement diet advice, fluoride therapy, and fissure sealants to preserve tooth tissue. Restoration. Minimal intervention. Cover and protect teeth with techniques like glass ionomer cement. Primary dentition. Consider stainless steel crowns on second primary molars to minimize wear. Dentinogenesis imperfecta. Monitor tooth wear closely. Extraction may be necessary for early affected teeth. Permanent dentition. Use cast occlusal onlays or localized restorations to protect tooth structure. Aesthetics. Primary dentition. Aesthetics are usually not a concern, focus on functional restoration. Permanent dentition. Consider composite or porcelain veneer to protect and improve appearance. Orthodontic considerations. Consult with orthodontist early, use removable appliances or orthodontic bands cautiously to avoid enamel damage. Management of molar incisor hypomineralization, MIH. Clinical presentation. Hypomineralization of first permanent molars and often incisors. Discrete opaque lesions, often asymmetrically distributed. Soft enamel prone to chipping, leading to exposed dentine. Increased susceptibility to plaque accumulation and caries. High prevalence, with figures ranging from 5% to 31%. Key aspects of management. Early identification. Review around eruption of first permanent molars for early diagnosis. Preventive plan. Implement proactive measures for high caries risk individuals. Mineralization promotion. Use CPPACP technology to deliver calcium and phosphate to tooth surface, enhancing mechanical properties and inhibiting demineralization. Treatment plan. Consider long-term prognosis of affected molars, malocclusion, and aesthetic. Restorative challenges. Poor mechanical and physical properties of affected enamel pose challenges for conventional restorative techniques. Options for restoration. Amalgam requires removal of excessive tooth tissue, leaving tooth vulnerable to fracture. Resin-based restoratives. Case integrity with hypomineralized enamel is inadequate, leading to microleakage and sensitivity. Glass ionomer cements provide temporization and maintenance of existing tooth structure, facilitating preservation for many years if regularly maintained. Preformed metal crowns, PMC preferred option for longer tension of affected molars, but requires excellent analgesia and patient cooperation. Aesthetic improvements. Conservative approaches such as micro-abrasion plus or minus bleaching or localized composite veneers for severe opacities and incisors. Management of hypodontia. Age-dependent approach. Infancy and early school years rarely require active intervention. Adolescents with ectodermal dysplasia, provision of removable partial or complete dentures can be successful. Mixed and permanent dentition phases, aesthetics becoming important, requiring replacement of missing teeth. Multidisciplinary approach. Team composition, pediatric dentist, orthodontist, prosthodontist, periodontist, maxillofacial surgeon. Early referral, essential for discussion and preliminary planning of treatment. Considerance, number and position of missing teeth. Age of the child. Attitude towards oral health. Wishes and expectations of the individual and family. Orthodontic treatment. Aim: consolidate spacing and position existing teeth optimally to support definitive restorations. Consideration: underlying skeletal or dentoalveolar discrepancies requiring surgical approach. Interim restorative solutions. During mixed dentition phase, removable dentures, composite veneers, or partial veneer restorations. Maintenance: throughout adolescence. Proactive preventive strategies. Essential for optimum dental and periodontal health, crucial for long-term success of definitive prosthodontic solutions. Definitive treatment option: post-growth, crowns, bridges, veneers, dental implants. Surgical interventions: orthognathic surgery, bone grafting. Geneticist involvement. Beneficial for adolescents contemplating implications of dental anomaly on family planning. Conclusion: managing hypodontia requires a comprehensive, multidisciplinary approach tailored to the individual's needs and circumstances at different stages of development. Early referral, proactive prevention, and consideration of interim and definitive treatment options are essential for achieving optimal outcomes and supporting long-term oral health and well-being.